All right, everyone. We are going to get started. Thank you so much for attending this webinar. I am pleased to introduce the 2024 winner of the APA Division 53 R. Rob Smith Excellence in Psychological Assessment Award. Dr. Kryzak is a psychologist at Nationwide Children's Hospital Child Development Center and an associate professor of clinical pediatrics at The Ohio State University. Her clinical and research work focuses on the assessment of children with neurodevelopmental disabilities, with a particular focus on improving access to individualized services for all families. She was instrumental in developing the virtual evaluation diagnostic assessment model during the 2020 global COVID pandemic, which allowed assessment service to continue by telehealth throughout restrictions in clinical services. This model translated evidence-based practice and employed novel telehealth observational measures, such as the autism detection in early childhood virtual, or the ADEC. To assess children of all ages at this time, Dr. Kryzak has since devoted her expertise in disseminating the virtual model to national and international audiences through Project ECHO Telehealth Autism Assessment. So I am so honored to be able to introduce this incredibly driven and effective psychologist. If you have questions, please submit them through chat as we go, and we will have a Q&A at the end of the session. So without further ado, here is Dr. Kryzak.
Hello, thank you all for joining today, and thank you so much to SCAP for giving me this amazing opportunity to speak with all of you today. Due to some technology issues, which tend to come up when we're using telehealth, Maura and I are sharing a computer today, so thank you so much, Maura, for that amazing introduction, and thank you all for being patient as we kind of switch thoughts here. But I have a lot I want to get through with us today, so without further ado, we'll get started. So just a quick note on me. Maura did a great job introducing me, so I won't spend too much time here, but I don't have any financial disclosures related to this presentation. And then while I've been working within the field of neurodevelopmental disabilities for 12 years, working on assessment with lots of different clinical service projects and research interests that have focused on increasing access to services through innovative use of technology and resources. My focus on telehealth really began in 2020, as I imagine that many of you can guess why. But within this presentation, I'm really hoping that we can talk more about the model that we created, as well as about support for telehealth in general. So I'm hoping by the end that you'll feel comfortable thinking about why we might want the telehealth option within a comprehensive assessment model, and what is some of the support that's out there so far for using telehealth to assess for autism spectrum disorder, as well as be able to identify some steps if you were interested in starting your own practice using telehealth as one possible mode of assessment within autism assessment. You'd have thought through some things that might help you develop that successfully, as well as think about one model in detail, and then think about some factors that might help you compare all the possible options that are out there for behavior observation through telehealth for autism symptoms. Now, before, though, we get into specifically thinking about telehealth assessment for autism, I want to talk a little bit about some of the framework that we use when we are designing any new service within our center. And so when we're thinking about developing any family-centered services, we want to be considering multiple factors to make sure that the service that we're creating is going to be effective to do what we want it to do. It's also going to be acceptable to both the clinicians and families that we're working with, or that are doing the actual services. We want to make sure that it's comparable in quality with what we're already doing or what we already know works well, and that we make sure that it's feasible. So it's going to be using the resources we have, whether that be the personnel resources we have, the time resources we have, the materials, as well as it going to be feasible to do for families or within the setting that we're going to be doing it. And then we really want to make sure that it's equitable. So is it going to be able to serve any person who needs this type of service across all the different factors, including things like age, race and ethnicity, socioeconomic status, and geographical location. And so for us, that means thinking about how to create a comprehensive and flexible model that's likely going to include a lot of different assessment pathways in order to be able to use the resources we have effectively, in order to increase access for all of the different families that we want to see and that need our services in an individualized way. This here, as well as move my time a little bit closer so I can keep track of that. So the reason that we are so focused on creating innovative, comprehensive models with lots of different assessment pathways is that we are in a crisis of access for autism spectrum disorder services. So for us, we're a center that focuses a lot on diagnostics of autism. And what we have is families often waiting years for initial assessment, and that's pretty common across the country. And so even though many children are having, or families are having first concerns for their children as young as 12 to 18 months, they're often still waiting years to get in for even just an initial evaluation to determine if autism is the reason behind some of the concerns that they're having. And those delays tend to be greater for certain parts of the population. So those from lower socioeconomic status, those from rural areas, those from underrepresented ethnic and racial groups tend to be waiting even longer to get those, even just that initial assessment. And then even after getting those initial assessments, families are then having to wait even longer to get into treatment services. And what we know is that this crisis is not going to be solved by personnel alone. So just training more people, getting more people involved isn't going to be enough to provide access to all the families that need these services. And so instead, we also have to think of innovative ways we can adjust our assessment models, creatively use the resources we have, creatively use technology that we have to be able to increase access to autism assessment services. And so that brings us to telehealth as one possible tool that we could use to increase access to services, particularly for families who are going to have difficulty getting in clinic for those in-clinic assessment services. So for example, when we have telehealth options, families who struggle with getting transportation to clinic or families who are just living very far from specialty services are able to use telehealth or options in order to bring those services closer to home so that transportation isn't a problem, location isn't a problem. We can also use telehealth options to decrease the amount of time families have to miss from work and the lost income that's related to that, as well as families aren't having to find childcare for other children if they're able to do that assessment within their home. And finally, telehealth really gives us a way of reducing stress for many of our families. So particularly for families with children where there's a neurodevelopmental concern suspected, these tend to be children that really struggle with going new places, adapting to new places, and so taking a really long drive to get to a clinic, often having to go from rural areas to inner city areas, can often be really stressful for families, especially when autism is a concern. And so being able to do this assessment in home allows us to be able to reduce some of that stress for our families. Having a telehealth option can also increase our agility as a clinic. So especially during times of crisis, such as a global pandemic that shuts down all in-clinic services, having a telehealth option allows us to be able to continue to see at least some of our families in order to prevent those wait lists from ballooning. So bringing back some of those themes that I talked about before, thinking about the research support that is out there broadly for telehealth. So I was surprised when I first started looking into telehealth, realizing that this is a tool that's been around for many years and has been studied for many years. So there are studies that go back to the early 90s looking at this as a possible approach for being able to do intervention services and assessment services in lots of different areas. Related to specifically to autism, there's several studies out there that have shown that being able to do autism intervention and parent coaching through telehealth has shown to be pretty effective in being able to get those interventions out to a broad range of people, acceptable to the families that we're working with and feasible. So being able to use this new technology to be able to effectively get those services out without using as many resources as we need to in clinic. Reviews have also shown that other types of testing, such as cognitive, language, and academic testing, at least for a certain population of children, particularly school-age children to adolescents, has also been pretty comparable to in-person results. So that review there is a nice one if you want to look further into those. I won't be talking as much about those types of testing today, but I know some of the questions that came in ahead of time was asking specifically about cognitive testing. So that review gives some great background information if you want to learn more about those types of assessments. And then there have also been several reviews looking at telehealth autism assessment models that were created both before the pandemic, and then lots of the great research that's come out on the models that were created and the measures and protocols that were created during the COVID-19 shutdown of in-clinic services. And those reviews have been able to show us that these telehealth models are pretty effective for looking at autism symptoms. They're comparable to many of the in-clinic evaluation services that we're doing, and that they are acceptable to families and clinicians that are doing these types of assessments. So I want to dig a little bit deeper into what our clinic specifically did. So despite the fact that many telehealth options have existed for quite some time, most of us were not widely using those services. So change is hard. Doing things in a new way can seem pretty impossible unless you have a good motivator. And so for us, that COVID-19 shutdown was a good motivator for us to look into these options. So like many clinicians and clinics across the country, we were faced with the decision of whether we wanted to shut down services for a period or whether we wanted to think about how could we at least see some kids be able to translate some of what we know works into a telehealth option in order to prevent our wait list from getting exponentially longer. For us, even shutting down for a couple weeks to a couple months was going to create a really big change in those wait lists that we knew were already long. And so for us, it was worth it to think about how can we quickly transition what we already know works into something that could work by telehealth. So bringing us back to those themes from the beginning, we were able to put together an interdisciplinary team of our clinicians here. So we worked with psychologists and psychology trainees, medical providers, speech therapists, our master's level clinicians, which include social workers, marriage and family therapists, clinical counselors, our genetics counselor, and our family advocate. And we were able to work with our clinical leadership to think about, okay, with the model we have so far, how can we adjust that model to be able to do it by telehealth to meet all 5 of these areas. So we wanted a model that was going to allow us to assess for autism spectrum disorder using our interdisciplinary team and continue at the same capacity that we were doing in clinics, or at least get as close as possible. We also wanted to create a model that was going to be acceptable both to the clinical teams that were doing these services as well as to all of our families who we were going to have a big ask of being part of this assessment and doing these assessments within their home. We wanted to make sure that that model that we were creating was going to be comparable in quality. So it's going to include standardized measures for autism assessment, including multiple modes of data collection, including interview, behavior observation, forms, and as much of what we could do in person done by telehealth, just in a different way. And then we wanted to make sure whatever model we were creating was feasible. So both within the resources we had in clinic, but also feasible for our families who we were going to be having a big ask in that we were now going to be doing this assessment within their homes. And we were going to need them to be a big part of this assessment. So we wanted to make sure that what we were asking them was going to work. And then we finally wanted to make sure that we were going to be creating a model that was still going to allow us to serve the same population of families. And you'll see that all ages is highlighted there because being able to see families from the earliest ages, so we see families as young as 18 months all the way up to 18 years old, and that is a strong value for our clinic that we want to continue to see children of all ages. And so we wanted to make sure that whatever model we were creating was also going to be able to see children across all ages. So much of the initial research looking at autism assessment by telehealth was really focused on younger children. And so we wanted to think about how could we extend what was already known, what we were already doing, to make sure we had a model that would be able to see all of the children that wanted to access our services. And so for a little bit of context, this is what our model looked like before the adjustments we made for telehealth. And so we had a two-part assessment where the first day families would come in to meet with an interdisciplinary team. Families would do interviewing with a psychologist and medical provider, while the child would meet with a psychometrician to do an ADOS and a speech therapist to do some speech testing. When we were finished with both parts of those assessments, we would get together as a team to talk about initial feedback we could give families, and then we would give family that feedback, which could include giving or ruling out a diagnosis if we felt like we already had enough information to do so, or explaining what next steps would be. So oftentimes our families would come back for another assessment, even when they did get or have a diagnosis ruled out, so we could learn more information, either to help make that diagnosis or at least be able to learn more about that child to give good comprehensive recommendations across all areas. So at that second appointment, they would meet with the psychologist and psychometrician to do some additional testing for older children. That would be cognitive and academic testing. For our younger children, that would be developmental assessment, and for all of our children, some sort of a measure of adaptive living skills, either through parent forums or in-person interviews. And then most of our families would come back for a feedback session as well with the psychologist. And so again, we would talk more about diagnosis in that feedback session, but spend really a lot of time talking about what's next. So what are the resources that they can access? What should be good next steps to be able to help families get to where they want to go next? So to work on different things that were concerning to them, to be able to decrease behavior problems, to be able to increase learning. And then many of our families, or they would all be given the option, but many families would take that option to come back and meet with one of our clinical care coordinators in a couple weeks to a couple months, where they would check in to see, okay, let's continue processing this diagnosis. What do you need to get started with next steps? Have you run into barriers with next steps? What are some early behavioral modification strategies that we can start talking about to get you to some of the next steps that you want to while you're waiting to connect to services? And so we have an interdisciplinary model that's comprehensive, that includes multiple sources of data, and also includes lots of time for us to talk through that diagnosis and get families to next steps. As whatever we do for assessment doesn't matter if we can't help families really understand where they're going next. And so when we started to think about, okay, how are we going to transition that model into telehealth? We wanted to make sure we were including multiple sources of data still. We wanted to make sure we were including our interdisciplinary teams. And so we began to think about what parts of that initial model were going to translate easily. So for us, we thought interviews were going to go pretty easily. Feedback sessions we could translate pretty easily. Clinical care coordination we could translate pretty easily. And actually, even if we weren't being kind of pushed to do these things, being able to have a telehealth option to do those things might actually help increase access across lots of different areas. So for feedback and clinical care coordination, they wouldn't have to come all the way back to clinic to do another appointment. So it actually could make our model more effective if we could do these things by telehealth. We also were able to pretty easily transition to some online forms platforms. So we could send families links to forms ahead of time through MyChart, or after we've done that initial session, and be able to get previous evaluations uploaded to MyChart pretty easily. So that cut out having to mail forms back and forth. So again, translated pretty easily to a telehealth model. What we knew would translate less easily with some of those behavior observations. So I know many of you asked whether you can do an ADOS by telehealth, and you cannot do an ADOS specifically by telehealth. And so Dr. Lord has created a measure called the BOSA, which will be in some of my slides going forward as far as an option for doing that behavioral measure by telehealth. But ADOS itself, obviously, because it's such a standardized measure, includes very standardized materials, is going to be difficult to do the exact same thing by telehealth. So we wanted to think about what could we do in that setting to still look at some of those same symptoms, as well as what could we do regarding that direct assessment of skills. So that was also going to be much more tricky by telehealth. So this was the model that we came up with. So it looks somewhat similar to our initial model, but definitely with some big key changes to allow us to continue to do those things we wanted to do. One of the biggest changes is that instead of doing the ADOS, we started doing the ADIR. So that is the Autism Diagnostic Interview Revised. And it's a standardized interview for autism symptoms. And so it asks parents a specific set of questions in a specific way, and allows you to score the answers that they provide similarly to the ADOS, where you're getting a score at the end that says whether this profile is more like someone with autism or less like someone with autism. And so that measure does take a little bit of time. So the other thing we did is moved that into its own separate section with the psychologist. And then we put that session first. And we did that intentionally because we wanted the information from the interview to be able to inform our behavioral observation that second assessment. So we knew we were going to have to be a little bit more flexible with that behavior observation. And so we knew if we had more information ahead of time, it might help us shape which behaviors did we want to make sure we were focusing on with that behavior observation, which were we pretty confident that parents were being able to report pretty accurately and we may not have to focus as much on, but having that additional information helped the team plan for that assessment better. And so during that second assessment appointment, the family would get to meet with our interdisciplinary team. And so one of the other big changes with this new measure or new model was that all of the team members got to be present for that behavior observation. And so while one person would lead it, typically the psychologist or the psychometrician would be coaching parents through that behavior observation, the rest of the team could give comments during chat, ideas, things that they wanted to see, adjustments that we needed to make sure that we could see the child well and hear the child well. And so we could work together to be able to see the behaviors that we needed to see. Speech would also do some adaptive speech testing during that second appointment. We'd finish up our interviews. At some point during those appointments, we would also collect parent forms, adaptive living skills, and then we would use the information we collected across both appointments to fill out a CARS, or the Childhood Autism Rating Scale, second edition. And so then we would take that information, and similarly to our first assessment model, we would put the family in a virtual waiting room, talk through what we had seen, and come back and give families information. So we could give or rule out a diagnosis, but we also may be letting them know that they would need to come back for an in-clinic appointment. So one of the key pieces to creating this model was also making sure we would have a process that if we were not able to collect the information we needed by telehealth, we could bring families back in. Now, obviously, during COVID restrictions, that meant that we would have to bring them in a little bit later. But we were very clear with families up front that this would be a possibility, both so that they weren't surprised if that happened, but also to let them feel more confident in what we were doing, so that they knew that if we did not feel confident that we had enough information to make or rule out a diagnosis, we would not push that. And so that's a key factor both for this model and any model that we're creating, is that we want to make sure that if we do not feel confident in what we're doing, we have another step that we can do. And so some of our kids would then go on to do cognitive or academic testing. Those tended to be our older kids, where we had some concerns for something like a specific learning disability or an intellectual disability within some limitations. So if you're trying to do cognitive or academic testing through a virtual means, it does work pretty well for older kids, but you have to have kids that are pretty willing to participate. So it's much harder to manage behavior through telehealth when you cannot be in the room, when you cannot fully manage the environment. And so while it did work well for some kids, that was not going to be an option for all children. And so a lot of times we had to refer back to schools to do some of that testing if needed, or those might be kids we bring back at a future appointment to just do that cognitive portion of the testing. And then most of our families will go, again, to a feedback session with the psychologist, and then if they would like to, can go to a care coordination appointment with our master's level clinicians, where we added some additional options for parent training, because we knew families were going to have more of a difficulty accessing those intervention services during COVID restrictions. So I know that was a lot. So just to summarize some of the major changes in this model, so we were able to keep our interdisciplinary comprehensive model that is going to include multiple sources of data. And one of the big changes we made is, since we knew we were not going to be able to do the same level of standardization with whatever behavior observation we were doing, we switched to doing the structured interview measure, standardized interview measure. We put that appointment first so we could gather that information to inform our team visit. And then we also created a flexible space for behavior observation. So I'll talk a little bit more about this later in the presentation about at least one of the measures that we used. But for our younger and older children, we didn't have a specific measure. So instead, we created structured behavioral protocols that we adopted from we had a research study going on where we were doing in-home observations. We adopted those protocols since they were using materials families already had at home to be able to do activities looking at symptoms related to autism. And we were using those protocols to look or complete the childhood autism rating scale. We also added some option for telehealth assessment, looking at cognitive and academic skills. And then we spent a lot of time trying to get previous assessments as well. So we would always do that in our in-clinic model, but it became more important during telehealth, where if there was an ETR out there, we spent a lot of time tracking it down and getting it so we could look at what testing had already been done or if they'd had a previous evaluation elsewhere. And then we continued to have a lot of space for families to process that diagnosis, think about next steps, be able to think of a concrete plan for accessing those next steps, and added some more behavioral intervention options within that care coordination to help them start accessing next steps while they were on wait lists for other places. And so while creating a new service line typically would take us a couple months, we really mushed this into a very short time frame. And so again, we wanted to make sure that we weren't losing a lot of time. And so we worked really hard for a couple of weeks to make sure that we got this up and running. And so after forming that team, we were able to start trialing a model that we were putting together, tweaking that model, adjusting it within the next week. During that week, our center was also able to get a telehealth platform up and running. So we were able to use Zoom through our Epic electronic medical record. Luckily, the hospital had already been in talks to get that up and running. They were planning on doing it over the next year, but ended up smushing it down into a couple weeks. So we were able to have that up and running so we could practice with that as well. And then we were able to get a model in place that we were happy with so that we could start trialing with families 2 weeks after we started our interdisciplinary team to come up with a model. We found that went really well. And so we started then developing training materials and having observations for the rest of our clinical teams to watch what we were doing and be able to help them feel comfortable doing this model until we got to about month and a half after we started, we were up to our full schedule again of interdisciplinary assessments. And so just to give a view of what that looked like, this is the number of telehealth assessment appointments that we were doing. So up until the middle of March, we had done none of them. And then by, as we said, about May, we were back up to about where our full capacity was. And so before COVID, we had capacity for 31 of these visits per week, and we were averaging probably about 25 with families either not showing up or clinicians having time off. And so we were able to get back to that average by the middle or the beginning of the summer and be able to sustain that through the time that we were 100% telehealth. So the next thing we wanted to do was think about, were we reaching those initial goals? So were we creating something that was effective, comparable in quality, acceptable, equitable, and feasible? And so we looked at the initial data we were able to collect in clinic to be able to answer some of those questions. And so since we didn't have the capability to bring families back in, what we wanted to do was compare families that we were seeing by telehealth to those we had seen in clinic. And so we were able to get a sample of families that we saw through March and the end of August 2020. And the reason we focused on that group was that this was the time that we were seeing families 100% by telehealth. So after August, we began to have some capability to bring families back in clinic with personal protective gear, protocols in place. And so we would leave it up to families as to whether they wanted to choose to be in clinic or choose to be by telehealth. And so when we were thinking about answering those initial questions, we wanted to just include a time when everybody was being seen by telehealth. although we were able to continue to use this measure far after that August 2020 time. So for the next year, year and a half, we continued to see a large portion of our families by telehealth until we had seen over 1,000 families using this model. And with this initial data, we were really focusing just on those almost about 400 kids we had seen during the summer. And then we compared them to the same time period of families we had seen the year previously. So from March to August 2019, that we had seen obviously 100% in clinic. And so the initial question we wanted to answer is thinking about that equitable question, is were we seeing the same population of families? And we found that generally, yes, we were. So when we looked at biological sex, when we looked at age, when we looked at what percentage of families were using Medicaid as an insurance option, and what families were from rural zip codes, we were finding generally we were seeing the same population. Now, for the first couple weeks, we were seeing families by telehealth. We did decide to focus on younger children because our clinicians felt more comfortable trying this measure out with families that had very young children. And so our age is slightly significant where the telehealth sample skewed a little bit younger, but by August, we were seeing a pretty comparable sample by age from 18 months to 18 years again. And so we were finding our model was equitable. We were also finding that our model seemed to be comparable to what we were doing in clinic. And so again, we didn't have the capability to bring families back in and look at whether we were getting the same diagnoses by clinic, mostly because we were still not doing standardized ADOSs since we were using personal protective equipment. And so we wanted to think about, were we at least diagnosing autism at a similar rate? Or were we seeing significant decreases or increases in that? But we found that we weren't. So we were diagnosing children with autism, ruling it out at about the same rate. And then, of course, we did have a group that we did defer on, meaning that there was a group of children that we said we did not have enough information by telehealth to make a final diagnosis, and we wanted to bring them in person. But we were surprised that actually ended up being a very small amount of children. So only about 11% of children were we finding needed to come back for an in-clinic appointment. And that rate held pretty steady over the next year and a half, so around that 11%. Looking at just that small group of children, we found that they did tend to trend a little bit older, which makes sense, right? So our older population tends to be kids that have more mild symptoms related to autism spectrum disorder or more complicated psychosocial histories or psychiatric presentations that can make making that diagnosis a little bit more difficult. We did not find biological sex, though, to be a predictor in the kids we weren't bringing back in clinic. So there was some concerns that girls tend to be a little bit different to assess. So we were worried that we might defer more on girls, but we did not find that to be the case. The next thing we wanted to think about is, was this model acceptable to the clinical teams that were doing it? So at the end of August, we had all of our clinical teams fill out a measure that we adapted. And so this measure we do have adapted from a measure that was created. So if you look up the AIM, IM, and FIM measure, you can find it. It's a great measure to be able to adapt to look at any sort of new service line that you're creating, to make sure that it's acceptable, make sure your clinical teams feel it's appropriate, make sure they see it as feasible with whatever setting or whatever new service line that you're creating. And we did find that our interdisciplinary clinicians were happy with this model. And so they were finding it to be able to do what we said it was doing. So again, answering those questions of, was it acceptable to our clinicians? Did it seem to be effective in doing what it was supposed to do? And was it feasible within our clinic setting? And our clinicians felt that it was. We also got to look at some initial data from families. Now, unfortunately, our return rate for the survey we sent out was lower than we would have liked it to be, although pretty comparable to the other kind of anonymous surveys we've sent out to families looking at their experience in our clinic. But for those that did return the survey, we were finding that they were generally positive results. So most of our families were feeling that telehealth was working pretty well to do this assessment process. And so again, thinking through those initial outcomes, we were able to create a model that was both acceptable to the clinicians we were working with and the families that we were working with. We were able to continue to include standardized measures, so both the ADIR and that CARS measure that we were able to continue to include within this model. And we were able to continue to use multiple sources of data to do a comprehensive assessment. And we were able to complete that in-home using materials families already had at home and minimizing that burden on them. So it was feasible within the personnel that we had, within the environment that we had, and without adding too much to that burden on families. We were also able to create a model that was equitable. So it was allowing us to see the same population of families that we were seeing in clinic. And it was effective in that we were able to continue to do interdisciplinary diagnostic assessment across ages at near typical rates, with only 11% needing to come back for a follow-up visit. Switching gears a little bit, I want to talk about what we learned about what everyone else was doing during the assessment, or at least a group of sites that were part of the Autism Care Network. So as we were in the thick of things doing our model, we were also curious to know what other sites had done adjusting their services with the COVID restrictions. And so we partnered with a group from the Autism Care Network and interviewed representatives from 17 of their sites across disciplines. And we asked them about what kinds of changes they made during those COVID restrictions, focusing particularly on any telehealth adoptions that they had made. And so what we found with the study is that there was a lot of variation on what people did, what people found that worked, what people found that didn't work, but there were some themes that underlined some of those changes. So many people felt like they were able to pretty effectively adapt their services to telehealth, although confidence did vary, with some sites being able to do similarly to what we did, where they were able to translate their entire model, and other sites feeling like they were pretty ineffective in being able to translate their services to telehealth. Of those that were able to transition their services to telehealth, most felt like they could make a final diagnosis in the majority of cases that they were seeing. And so if they were asked to kind of estimate how many cases were they making a diagnosis versus having to bring families back in, centers estimated between about 80 to 95% of cases they were able to successfully make a diagnosis by telehealth. And most centers also had that clear plan for what to do if it wasn't working. So that's going to be, again, a big piece to this is we need to make sure that there's a plan in place to make sure that clinicians don't feel pressured to make a diagnosis when they do not have enough information to do so effectively. Another thing that many providers noted was that the kids that were hard to diagnose by telehealth were also the kids that were hard to diagnose in clinic. So again, they tended to be kids with either more mild symptoms or other factors that made it difficult to pull apart those symptoms from other factors, such as complex psychosocial histories or psychiatric presentations. And so again, hard to diagnose by telehealth, they tended to be hard to diagnose in clinic, but having that additional in-clinic information was often helpful. When thinking about, again, what worked well by telehealth versus what maybe was a little more challenging to do by telehealth, similarly to what we found at our clinic, most providers felt that interviews and feedbacks worked really well by telehealth. They didn't notice any major changes in rapport with the families that they were working with. Behavior observation, though, was definitely indicated as the thing that was most challenging to translate. So lots of different centers use lots of different types of measures or protocols to be able to see those symptoms. Some felt very strongly that this was working great. Others were like, oh, not quite as sure. But in general, this tended to be the thing that people were most wanting more information about. There was also pretty limited data on whether centers were able to do any cognitive testing. So most centers did not opt to even try doing cognitive or academic testing. For those that did, they felt that the limits, there was definitely limits to what's available so far, mostly by age. So definitely school age to adolescents are going to be who's most appropriate to do these measures with. Particularly those with fewer behavior concerns, because again, it's really hard to manage behavior through telehealth in the same way that you can do in clinic. thinking specifically about that observation, looking at symptoms related to autism, clinicians definitely noted some clear strengths of being able to do this observation by telehealth. So many felt that they were able to get a more naturalistic observation of parents and children and other family members through using a telehealth modality. So it allowed them to see behaviors that they might not be able to see in clinic. So in particular, some of the factors they noted was children who are particularly anxious, who may really struggle with warming up in clinic. We were able to see them actually interacting in an environment that's comfortable with people they were comfortable with. And so we would often be able to even better be able to pull apart what were some symptoms related to anxiety versus what were symptoms related to autism spectrum disorder. We were also able to often see more unique interest or repetitive behaviors that we might not be able to see in clinic because those materials aren't available. And so being able to do this observation at home allowed children to be able to use what they're typically using or do what they're typically doing within those home environments. The other big strength that was noted was that being able to include families more in that assessment process. So where we not just were having them observe, but actually having them participate and be an even larger partner within that assessment process really strengthened the relationship between the family and the clinician. There were definitely some challenges also reported. So many of these measures protocols are new. And so there's not as much research as there is, for example, for something like the ADAS or something like the ADIR. And so there were definitely some concerns that are we getting the same data that we expect that we're getting in clinic? There's also just less data available on how social behavior varies by video. So many of us have observations, like for example, eye contact tends to be one that is very hard to judge if you're just talking to someone by screen. So I'm gonna look most like I'm making eye contact with you when I'm looking at the camera and less when I might actually be looking at your face. And so we have to think about ways that we can adjust those behavior observations to account for some of those differences. And so, for example, having families talk with their children and being able to watch that interaction and look for eye contact, look for those nonverbal behaviors as they're interacting with each other versus interacting just with us through the camera can help with that, but we still may not have full understanding of what all those changes may be. So more research is needed in that area. And then you also just have less control over the environment when you're doing things by telehealth. So there's less standardization, there's more reliance on families to administer the assessments instead of people who have been doing this for many, many years. And so that's just going to be something that's part of a telehealth observation. Another question we asked is what helped people be successful? So certainly having more information, doing literature reviews, doing trainings, having previous training in parent coaching really helped people to be successful in starting telehealth. But most people indicated that really the thing they had to do most was just try it. So most felt very uncomfortable doing it until they actually did it. And then were surprised at how well it worked, how much it seemed like what they were doing in clinic. Although finding that, having some opportunity to observe some of your colleagues or working within a team was also really helpful as, trying something new with other people can feel more supportive than trying it on your own. Clinicians also felt that institutional support was important. And so some of the factors related specifically to the COVID restrictions that were in place that were putting a lot more pressure on clinicians themselves, but also being part of an organization that supports innovation, that has access to technology that you need. So you can't do telehealth without a telehealth platform, as well as support around helping families access that technology was important as well. And then finally, we asked clinicians what were they thinking about since we were doing this interview as we were coming out of some of those COVID-19 restrictions. What were they thinking about telehealth for the future? So most people who were using telehealth felt like they wanted to continue it in some way, even after those restrictions ended. So they were starting to think about how were they going to triage families into those telehealth services. Most knew that they weren't going to be doing this full time. But if we were going to keep this in some respects, who would be the best fit for it, as well as what would be our plan for those that this didn't work for. And then also, how would we continue to advocate to make sure that these services could continue? So there was a lot of emergency services or emergency protocols put in place by insurance companies, by our community partners, by our licensing boards that were changing now that those restrictions were ending. And so I know a lot of you asked about insurance reimbursement, and I would strongly recommend checking with insurance providers that you work with. So a lot of Medicaid, state Medicaid varies a lot. So some states are still very accepting of having telehealth assessment practices. Others have put more restrictions on whether they'll reimburse for those services. But it's important for us to continue to advocate, not only for whether the assessment is reimbursed, but whether the measures that we're using during that assessment are going to allow families to be able to access intervention services afterwards. So some insurance providers have specific measures that need to be in those assessments. Luckily, the ADIR tends to be one. If you don't have an ADOS that you can use, some insurance companies also allow the cards to be used. And similarly, you want to make sure that the evaluations you're doing are going to be acceptable to the community partners you're working with, so schools, other county support providers that may be out there, intervention sites that you'll be referring families to. And then thinking about licensing differences as well. So again, there was a lot of emergency licensing flexibility that was put in place during COVID that was lifted. But there are options such as SIPACT or being able to have cross-state licensing reimbursement pieces or reciprocal agreements that will allow you to practice across state lines. And then thinking about whatever telehealth services you're creating, are they ethical? Are they effective? APA has a ton of great resources just generally about telehealth, including updated guidelines, webinars, materials that you can use to think about is what you're doing compliant, if you're thinking about adding telehealth to what you're already doing. And so we talked about some of these challenges and benefits, but I want to use the rest of the time we have left to think about choosing a telehealth behavior observation tool. So as we talked about, there's definitely some challenges to doing this by telehealth. We'll have to accept that the environment is never going to be as controlled as it is in your clinic. There's going to be environmental things that happen, just trying to make sure that the family is in view of the camera, that you can hear everything, that families are able to adequately carry out some of the material or behaviors that we want them to be able to do, to be able to see some of the behaviors that we want to see by video, is just going to be more challenging. But there also are a lot of benefits. So getting that natural observation can be really effective. And being able to strengthen that partnership where we really have families as part of that assessment process is really rewarding. There are many measures out there. I have some in parentheses because every time I put together a presentation like this, I find more measures out there that are being created and validated as possible measures or protocols that you can use to assess for autism symptoms by telehealth. A lot of these measures vary based on things like age, but also on many other factors. And these are important factors to consider when you're thinking about which of these measures is going to be more appropriate. So there isn't just going to be one measure that is going to fit for your setting, for your clinical style, for what's important when you're thinking about these evaluation processes, as well as considering how many of these do you have to do each week. And so you want to think about level of structure. So is it a very structured assessment where you have to do things specific ways in order to be able to code it? Or is there more flexibility in what you're doing? So for example, with the observation protocols we have kind of a menu of activities where there's some things we do with every kid, and then other things we add in if we want to see other behaviors, or if we haven't been able to see other behaviors during those more the activities we do with everyone. We also want to think about the materials needed. So how specific do those materials need to be? Are you going to have to mail materials to families? Can we use what they already have in home? How many materials are there? So for our assessments, we wanted to make sure that we could use materials that families had in home, because there was no way we were going to be able to mail 31 sets of materials back and forth. But also we wanted to make sure that we weren't putting any sort of burden on families to go out and buy materials. We wanted to make sure whatever we were using were going to be adaptable with what most families would have at home. We also wanted to think about that level of caregiver involvement. So, did families have to do training ahead of time, or were we able to coach them in the moment? We wanted things where we could really coach people in the moment, not put additional burden on families to learn things ahead of time. And then how is the data collected? So some measures have you collect videos ahead of time. The observation protocols we did looked more at real time, so where we would coach families through doing different activities in home. And so we saw the benefit to that of being able to be more flexible and adjust things as needed. And then what data is given? So are we looking at qualitative observations that you're going to use to go through the DSM criteria? Are you going to be able to use those observations to fill out another measure like the cards? Or is there a standardized scoring system that's part of that measure? And so just to give an example, one measure that we adopted was the autism detection in early childhood. We liked this measure because it was a great secondary screener. It's very quick, it's easy to administer, you don't need a lot of training or experience. We figured it would be something that we could coach parents through pretty easily, and there's no need for standardized materials. So there's a set of materials we want, but they're pretty easy to adapt from what most families already have at home. And so it already had pretty well-established properties as an in-clinic measure, both as a screener, but also they had been looking at how if it could be used as a diagnostic tool by people who did have experience diagnosing autism spectrum disorder, and was performing pretty well when the high-risk cutoff was used. And so we worked with the original author to adapt this measure into a virtual measure using the same activities where we would coach families through using materials they had at home. And initially we found that it was working pretty well. So we were able to show that it had pretty acceptable diagnostic accuracy within a clinical sample if we use that high risk cutoff. So again, for a screener, you'd use more the moderate cutoff because we want to make sure we're not missing anyone who could possibly have autism. But when we're thinking about it more diagnostically, we want to really be thinking about that high risk cutoff is going to be the best predictor of whether this child had autism. We found that using the ADEC with the ADIR was the best combination. So they both contributed significantly and separately to that final diagnosis. And we found that the ADEC was slightly negatively correlated with age. And I will say that we did extend this measure. So it was supposed to be used up till 3. The original author was starting to extend it up to 4 years old. And so we did that with our virtual measure as well. And we did find that for those 3 to 4-year-olds, especially those that were more verbal, this measure alone often was not enough to look at all those autism symptoms. So those kids tended to score lower whether or not they had autism. And that's because those concrete tasks were things that kids with more mild symptoms of autism could often do. So they would respond to their name. They would be able to play peekaboo, but when we would add some tasks, some pretend play tasks, we could often pull for some more flexible language, some more flexible play. If those symptoms of autism were there, we tended to see them. And so the tasks were still helpful, but we just kind of had to add to them. And the score wasn't going to be as helpful in that final diagnosis. So I was going to show a video example, but I am out of time. But I do have access to a couple different video examples. If you're interested in looking more into these types of measures, you can reach back out to me and I can share our video examples, share our materials. But in conclusion, we were finding that autism assessment through telehealth is pretty effective, comparable, feasible, but it will always be one tool in a comprehensive assessment model. So this is not going to work for every child. It does work pretty well for a large majority of families. We also found that it was a pretty acceptable to the families we were working with as well as to our clinical teams. And it does have the potential, more than anything, to increase accessibility across lots of different populations who might struggle with getting into in-clinic services. And so again, what we're doing with this is adding it as one prong to our comprehensive models so that we can create these flexible assessment models that are really going to increase access to services by individualizing those services, individualizing our use of our resources to meet families' needs. So I have all my resources in here. So I've been told that they'll be able to send out my presentation so that you'll have access to those resources. I just want to thank SCAP again for giving me this opportunity to speak with all of you, and thank all of the teams, personnel I got to work with here, as well as all the families who were so willing to jump in. And then, as I said, definitely contact me if you want to talk more. I really love working with individual providers to talk through how they might adjust their services to be able to add a telehealth option. And then we also do a free training as part of our site here that's over a couple weeks that goes more into depth in the types of behavior observations that we do and adjusting models using medical evaluation, speech evaluation, and then the measures that we do. So I know I'm pretty much out of time, but I'm gonna look to see if I can see some of the questions here.
Thank you so much, Dr. Krysak. I will help with some of the questions. Don't
Thank you.
worry about it. Just wanted to say thank you again for the amazing webinar. For all the participants, like she stated, we will have the slides and the recording of this posted online to our website very soon after, and we will also send out the CE certificates within a few days. So just please be patient to receive that. But if you need to drop off at the end of the hour, we will be sharing all of our resources online. We do have time for a couple questions if you are up for it, Dr. Krysak.
For sure, yeah. I'm willing to stay on too and answer any questions if we can get
Yeah,
to them.
absolutely. We probably won't get to all of them, but like she
No.
said, feel free to reach out to her. Let me go through a few of these. First question, how did you handle divorced families when the identified parent went back and forth due to shared parenting?
That's a great question. So as much the platform that we were using would allow multiple people to be on the telehealth appointment at the same time. So if we had families that were at a place that they were comfortable working with each other, we could have two sets of parents on the video at the same time. Most of the time we were usually doing that observation in only one setting, but if families felt strongly that this child looked differently in different settings, then we would certainly be willing to do an observation in both settings, just like we would be willing to bring both parents in. For parents that maybe aren't as capable of kind of being in the same room with each other yet, doing the interview separately, we would do that separately by telehealth as well.
Okay. Could you also share about your experience using this model with families from diverse racial and ethnic backgrounds, if it differed, just what your experience is with this?
Yeah, so I think that that's a great question. So while we were able to see all of the families that we typically would through this model, we didn't collect specific data about the families that were able to fill out those surveys. So we're not sure if it varied by different ethnic or racial backgrounds, but certainly we felt pretty comfortable working with all of the same families that we would in person. Certainly telehealth does provide its own barriers, right? So if you don't have access to the technology to do telehealth for some reason, or you don't feel comfortable using that technology, it's going to be more difficult. But that's why having this as part of that in-person services, both of those options is a good idea. But most families were able to do this by using any platform they had. And also because we were really flexible with our materials, we could work with different families who had any sort of toys. So we could do the ADEC with a set of dishes if we needed to. And so for the majority of families, we could make whatever toys they had work. And I think felt pretty comfortable being able to walk families through. So again, getting that time to really help families understand what we were doing, why we were asking to see these different behaviors, I think helped families where maybe if autism wasn't part of your culture, gave them a chance to really see what behaviors we were looking at, what was working, what wasn't working. We also felt interpreters were pretty easy to use using this model because you have the interpreter right there in the camera with you. So you're all kind of working together as a group to be able to do these assessments. So I wish we had more data, but that is what we have from my experience at least.
Yeah, wonderful. Um, what are the implications of excluding the ADOS? Did you get any pushback on not using it? Would you recommend using ADOS 2 if possible, or ADI is valid enough and will stand up if scrutinized?
Yeah, so I would certainly say that our community partners and our insurance companies that we worked with were comfortable with us using the ADI. So if we're thinking about are they going to ask for one measure or the other, as long as one of them was in, they were happy with. But if we're talking about actually what behaviors we're looking at, I love the ADOS. If we can have that as part of our assessment, it's a great measure. I would suggest anyone who hasn't who wants to do autism assessments spend some time learning how to do the ADOS. But it is not the only measure out there that can work for looking at those symptoms. And knowing what behaviors are looked at through a structured behavior observation like the ADOS can really help you do those things more flexibly if you need to through a model like this. And so I would definitely say there were those kids that 11% were getting them back in and doing an ADOS in person was helpful and getting us some additional information. But for most of the families we worked with, it was working really well. Our community members felt comfortable. We were able to write up those observations, and we're still looking at a lot of the same behaviors. I mean, the activities aren't going to look that much different from some of the things you're doing within the ADOS. And so I think it's interesting you find you're able to get a lot of that same information, but having some of those other standardized measures like the CARS, like the ADIR, does help other partners feel more comfortable with the assessments that you're putting out. That's a great question.
Absolutely.
Oh, very good.
We're getting really close on time, so I'm just going to do one more question if that's okay. I would love for you to talk about how does insurance coverage impact telehealth use? We also have a lot of questions just about like providing families with technology or helping them purchase technology to conduct telehealth. So it's a lot about resources, insurance, coverage, all of those things.
So families didn't have to purchase anything for what we do. So we use Zoom through Epic. So as long as you had a device, you could do this. So we did a lot of them on smartphones. We did them on iPads. We did them on computers. And smartphones actually work really well because they're very mobile. So especially if you could have two caregivers present, one to be a camera person, one to be the administrator, that worked really well. But we could make it work even if we only had one parent by moving that phone around as needed. We needed to do a lot more coaching to get families to do that as we needed them to, but it worked really well. And so this shouldn't involve families getting additional technology. Now, internet could be a difficulty. So if some of those same families that we know struggle with getting in clinic, they also struggle with having good internet providers. And so that was the one thing that sometimes technology-wise would make telehealth more limited. But for the most part, families had a telehealth or a telephone service that worked pretty well to allow us to do this assessment. Insurance is really going to vary. So if you are thinking about doing this, I would strongly recommend consulting with the insurances that you are mostly going through to make sure that telehealth is an option. It's also the thing that's probably changing the most. So, during COVID, everybody was like, yeah, we'll cover everything. But as we've gone back in service, what I've seen is that a lot of insurance companies are still covering telehealth, but at a reduced rate because they're like, well, if you don't have to bring families in person, then we don't have to pay you a office fee. And so you want to make sure that you're checking to make sure that this is going to be a viable option under whatever model you're using for reimbursement as well. And some places are getting to the point where they don't want to do any telehealth assessment services. So they'll cover feedback, they'll cover interviews, but the assessment itself, they want to be done in person. So you just want to make sure that you're checking with the providers you're working with.
Absolutely. So thank you so, so much again for this wonderful webinar. And thank you to all of our participants for staying engaged in all the wonderful questions. Like we stated, all of the resources, recordings, slides will be posted online, as well as the certificates will be sent out within a few days. So thank you again to you, Dr. Wendell, everyone. Thank you so much.
Thank you, and definitely get in touch with me if you are interested in talking more about what you're doing or what we were doing. We love to talk about this. So.
All right. Thank you, everyone. Have a great day.
Bye.